Assalamualaikum everyone. Am I audible?
Walaikum salam. Yes, Dr. Kawal.
Welcome to the neurosurgical case room. After a long hiatus, I'm really happy to be back, and I'm sure you all of you are as well. And it's going to be a shorter session, and I have also reduced the days of the sessions because I wanted to sustain this long term, and that's not going to be possible if the sessions are more frequent and longer. But let's hope we can get the best of the time that we have here. So, we are going to start with the anatomy of the lateral ventricles. And if we are not going to spend a lot of time on, a lot of text today, we are only going to build the orientation and, the anatomical know how. Tomorrow, as a part two, we are going to focus more on the text and the borders and the boundaries, etc., etc. Please mute yourself. Anybody who has not muted themselves yet, please mute yourself so that we can proceed. So today is just the orientation. This is a very easy illustration from Roton. All of these images, almost all, apart from probably a few, are from Roton, but they are obviously not in the same sequence. So let's get back to our previous pattern of drawing stuff. This thing here that you see, what is this? This is the lateral ventricle, right? This is the basic illustration. Very simplified, easy to understand, but it shows two other really interesting structures. What are those? Now, one of them is very uh, easily visible, this egg-like structure around which the lateral ventricle has wrapped itself. What is this? This is thalamus, right? There is another very interesting structure. Lateral ventricle is surrounded by interesting structures. Please keep yourself muted. The other interesting structure here is this thing. If you can see, it's going here and here and coming like this. Apparently, this C shape is a favorite among all these deeper structures. You can see the thalamus as the epicenter. On the thalamus, there are a few other structures that wrap as well. One of them is shown here. You can see that the fornix is wrapping around the thalamus and going down. The ventricle, the lateral ventricle, has also wrapped itself around the thalamus. It's sitting right in between. Then there are two other structures, especially one which is very close to the thalamus. Can somebody mention it? It's not in this picture. There's another structure that goes around here. Anybody remembers it?
The caudate nucleus.
That's right. We have the caudate nucleus, which would be coming in the slides later on. And there's a structure which goes above all of it. Let me draw. There will be a structure which will go like a C, more or less, sort of, following
Corpus
the cadaveric,
callosum.
corpus callosum. So these are four main structures that we need to be aware of when we are talking about the lateral ventricle and its relationships. It's easy to understand if you have a clear idea of the orientation, because then it would make understanding the walls and the parts, etc., easier. Let me clear all of this. Who is in the chat box? Okay. So, how many parts would the lateral ventricle have? There's a frontal horn, right? And then this portion would be the body.
Body,
Yeah. And then we have the,
atrium,
The trigon.
this would be, yeah, the trigon or the atrium. Then we would have occipital horn. And then we will have the temporal horn. These are the major structures. Now, if you see, thalamus is wrapped by the lateral ventricle and corpus callosum goes on top of it. So, understandably, a lot of the relationship is going to be these structures. Corpus callosum is going to form the roof of a lot of parts of the lateral ventricle, not all, but most. And thalamus is going to form the floor of at least the body, and some portion of the walls of the atrium and the frontal horn as well, whereas it will contribute to the roof and the sort of the medial wall of the temporal horn. We are not going into the discussions of the walls, etc. today. We are only going to establish the orientation. There are a few other things where this this fornix and the thalamus meet. There is another structure which is called choroidal fissure. So what exactly is this is? That this is a double-layered pia which can have some portions of ependyma. It is highly vascular and it ultimately ends up forming the choroid plexus, right? This ends here. This does not go all the way around the ventricle. It starts somewhere around here, gives in C formation and stops somewhere around here at the, what is that called? Can somebody mention? Inferior choroidal point, which is in the temporal horn. Now let's move to the next slide. What view is this? Where are we looking at the lateral ventricles from?
Axial view.
Yes, this is the axial view or the top view. You are seeing a 3D illustration, a very basic illustration, and we are looking at it from the top. So what we see is the axial or the transverse orientation of the lateral ventricles. You can now say the thalamus goes mediolaterally. The direction is, let me draw here. And this is the direction. It goes mediolaterally. So it's not completely in a single direction. So the walls that it is going to contribute to the body and the frontal horn is going to be very different from the atrium and the temporal horn. Why? Because it is going slightly laterally. Medial to lateral is its normal direction. Apart from it, you can also see the fornix here, and this here is, let me draw. This is the temporal region, by the way, because you are looking at it from above. So this is the temporal region, this is the temporal horn, along which you can see the hippocampus, some portion of the fimbria, which goes on to make fornix. And then both of these crura, they combine to form the body of the fornix, which is somewhere around here, and then the body splits to form two of these columns. So fornix sort of ends up in two separate structures, just the way it started. And the only thing is, it traverses from an inferior to superior direction, and then from superiorly, it goes anteriorly, and then inferiorly. So it makes a curve. The curve is slightly spread out. It's not completely in the sagittal direction. If you look at the lateral view only, you would think that it is following the curve of the sagittal view. I hope I'm making sense here. If you see, you would feel that this is in the same plane, but it's not. It's spread out. So when we see the axial direction, the axial sections, we see that the fornix is spread out. It's not completely in the same direction. Like thalamus, it is also changing its direction and orientation from medial to lateral. Why is that important? Because this means if we make a section here, we are only going to find some portion of the column and the body. We will not find the crus, and we will not definitely not find the fimbria. They will be more on the lateral side. Whereas if we make a cut here, we are only going to find the crus. So it's changing its orientation. I hope I have made myself clear. Let's move to another illustration. Which view is this?
Coronal.
Anterior, coronal.
Yeah, both of you are right. This is an anterior or the coronal view. And let me turn on my marker again. You can now see that the fornix and the thalamus both are indeed changing their orientation from medial to lateral. And even the lateral ventricle is doing something similar. But now you can see this is the frontal horn, right? And this portion here is the frontal horn, the bluish thing. And under the frontal horn, you can see fornix going below. So it is going to contribute to different portions of the frontal horn. It's going to contribute to different portions of the body and completely different portion of the atrium. So even though the structures are same, the wall contribution is going to be very different. Let's move on. Let's make things more interesting. You can now see the structures that we were talking about previously. You can see which structure is this? The green thing?
The caudate.
That's right, this is the caudate nucleus, which is also wrapping itself around the thalamus. And on top of it, we can see the illustration of corpus callosum. Let me clear this. So you can see corpus callosum is on some portion of the lateral ventricle, it is superior. Then it goes slightly posterior. Then it also goes superior to the, what is this portion? Temporal horn, right? So it's going to contribute to the roof of the temporal horn. But then again, it's going to make a curve, come anteriorly and under the frontal horn. So now the contribution here would be very different than the contribution here. Here it is going to contribute to the anterior wall and the floor, whereas here it was making the roof. So it's really important to understand how the structures that are lending their walls to the lateral ventricle are changing orientation themselves. Are we all on the same page till here?
Yes.
Okay, moving on. Why are we back to this image? All of you remember this one? We did this extensively while we were doing the hemispheres. So I think by this point, all of you would have recognized that this portion is my favorite. What is this entire thing?
Inferior frontal gyrus.
And why is it important?
Broca's area.
That's
Broca's
Broca's. Yes, on the dominant side, this is Broca's. Right above it, we are going to have the middle frontal gyrus. Somewhere around here, we have spent considerable amount of time doing the anatomy of these structures. Then what do we see here? We see the precentral gyrus and the postcentral gyrus, which means that this is going to be the central sulcus. Then there was another structure that we covered really beautifully. What was this?
Pelvian.
That's the lateral sulcus or the sylvian fissure. And on top of it, there was a beautiful gyrus that wrapped on it. What was that?
Angular. Angular gyrus.
No.
Supramarginal.
Yeah,
Supramarginal.
I think you have all forgotten. There were two parallel sulci. One was sylvian and the other one was superior temporal
Superior
sulcus.
temporal.
Yeah. So the superior temporal sulcus, its end is marked by angular gyrus, whereas the lateral sulcus or the sylvian fissure, its end is marked by this upturned gyrus, which is the supramarginal gyrus. Both of these are together, and both of these form what?
Vernix.
Vernix, and there is another name for this. Inferior parietal lobule, right? This is the inferior parietal lobule, this portion here.
Yes.
And now we have delineated more or less of the important structures of the frontal lobe, the parietal lobe. There is another thing. Let's come down to the temporal lobe as well. Why leave it out? This was the superior temporal gyrus. Let me clear this. This one was the middle temporal gyrus. Why is it important? It is important because we know, I'm going to use white color so that it's visible, among all this chaos, that the lateral ventricle is going to go something like this, right? This is a very rough sketch, but you all get the gist. This is how it is going to go. So, right under the inferior frontal gyrus, if we take away this portion, if we dissect this and go in depth, we are going to find the frontal horn. If we dissect out the pre and the post central gyrus, which was this area, let me mark it now with the blue. So if we take this portion out, then we are going to find the body of the lateral ventricle. If we go slightly posteriorly, underneath the supramarginal gyrus and the angular gyrus, we are going to find the atrium. Please keep yourself muted, whoever this is. Let me see. Dr. Ken, I am not able to mute you. Please mute yourself. So, just underneath the supramarginal gyrus and the angular gyrus, if we dissect deep, we are going to find the atrium of the lateral ventricle. And once we come down under the middle temporal gyrus, we are going to find the temporal horn. So all this superficial or topographical anatomy is important when you do not have neuronavigation in your OR and you want to build a trajectory. My supervisor was very adamant on learning a good trajectory so that you're not dependent on any other add-on. Let me clear all of this. So when we look at the lateral view of the brain, we should be able to have this mental map. If you listen to the Roton videos, you would realize that he keeps saying having a mental map or a mental navigation. So you would know that under this pars opercularis and pars triangularis, you're going to find inferior frontal gyrus. Under the pre and the post central gyrus, you're going to find the body. And under the inferior parietal lobule, you're going to find atrium. And under the middle temporal gyrus, you are going to find the temporal horn. Am I clear?
Yes.
So let's look at all of this step by step. Let's follow the dissection. You have understood the topographical anatomy. This is after we have retracted the inferior frontal gyrus. You can still see the inferior frontal gyrus here if you follow my cursor. Underneath it, you have the insula and the short gyri. Once you take these away, you're going to encounter frontal horn. So the orientation is flipped. This is where the frontal lobe was, and this is here the frontal lobe is. So do not confuse the orientation. You can still see the central sulcus on this image. This is the central sulcus, and you can also see the pre and the post central gyri. But what portion has been taken away completely? Rest of the frontal lobe, right? They have not only stopped at the inferior frontal gyrus, they have completely dissected all of the frontal lobe apart from the pre and the post central gyri. And now you can see some portion of the body. And if you follow this direction here, this is the frontal horn. If you come back, they have also dissected portions of the inferior parietal lobule here, and you can take a little peek at the atrium of the lateral ventricle. Is it clear?
Yes.
Yes.
Okay, moving on. It's a similar image but different orientation. Always orient yourself because it's a common mistake. I still keep doing it. Always orient yourself before commenting on any new image. You can take a look that the frontal lobe is now anteriorly here. They have taken it away. You can see the lateral ventricle here. And if you follow the curve, They have also taken away the inferior parietal lobule, so you can see part of the atrium. And if you still keep following it, they have also taken away the middle temporal gyrus from here. You can see that the superior temporal gyrus is still intact, and the inferior temporal gyrus is also still intact. Middle temporal gyrus has been dissected away so that you can now have a peek at the temporal horn. Let me move. It's the same image with just different steps of dissection. The dissection has been more or less completed. They have only left the pre and the post central gyri so that you won't be able to see a lot of the body, but you can see the frontal horn, you can see the atrium here, and you can also see the temporal horn here. Let's move on. What surface is this?
Medial surface, sagittal view.
That's right. We have suddenly shifted from the lateral surface to the medial surface. Why? Because now we want to see the core structures. All the structures that we saw on the illustration, you can now see, let me turn on my pointer again. You can now see the septum pellucidum, right? And then this portion here is the thalamus, which goes egg-like. Apart from that, you can also see the crest of the fornix. This is how the fornix continues, sort of goes underneath, which we obviously cannot see, but it crosses the foramen of Monro. It continues inferiorly. You can see the fimbria here and the hippocampal body where it ends, sort of. And then you can also see the inferior choroidal point where the choroidal fissure ends. The choroidal fissure does not continue down the entire length of the temporal horn. So on the medial surface, if you go deep down, you're going to find these deeper structures. From the lateral surface, we are going to find obviously the gyri and the sulci. Let me see if I have an image of the basal ganglia. Okay. This is again a sagittal section, and you can now see the frontal horn, which is visible. Apart from the frontal horn, you can also see the indentation of the head of the caudate nucleus here and the body of the caudate. This portion here is the thalamus, even though it's not labeled here. But what is interesting here is, what do you see? What is this? Forceps minor, which is a part of?
Corpus callosum.
That's right. Forceps minor and forceps major are two different white matter tracts which are parts of the corpus callosum. So if you see, forceps minor is making some portion of the anterior wall of the frontal horn. It goes under the frontal horn as well, some portion of it. Forceps major is going to contribute to the wall of the atrium. Let me move. This is a cross section and an illustration, obviously, so that it's easier to understand the relationship if somebody still hasn't. Let's come back on this side. What cortex is this?
Insular.
Insular.
So all of you can easily imagine which cortex was here. Right over the short gyri of the insula, which cortex was there that we
The
dissected out?
opercula, the
Sorry?
frontal, inferior frontal gyrus.
Yes, inferior frontal gyrus. So somewhere around here, obviously it's not going to be accurate. It's only going to be our imagination. Somewhere around here, we are going to have the inferior frontal gyrus, which has been taken away. Then we are going to have the short gyri of insula. When we go deep, we are going to find all the core basal ganglia structures that we have covered very thoroughly. The extreme capsule, claustrum, the external capsule, the putamen, the lentiform nucleus, the globus pallidus, etc. Afterwards, you are going to find, let me see, my screen changed. Just give me a minute. Something happened to my screen. Right underneath, we are going to find the internal capsule, the anterior limb, the posterior limb, and the genu. Medial to internal capsule, we know there are two structures. Anteriorly, it is going to be caudate. Posteriorly, it is going to be thalamus. When I'm saying anterior and posterior, I mean it in an axial direction. So, what does this mean? This means that while we are at Foramen of Monro, when we are operating patient endoscopically or from even from a transcallosal route, when we are near Foramen of Monro, there is one structure that all of us know to preserve, but there is another structure which we are not, as consciously aware of. There is a structure that we all need to preserve. What is that? It's not marked here. What's the one
The septal
structure?
vein,
There is another thing.
the
Fornix.
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 That's right. We have fornix right around the foramen of Monro. When we are doing the foraminal approaches, we need to be very, very careful of putting any extra retraction over the fornix. But on the lateral side, genu is also very, very close to the foramen of Monro. What does this mean? What does the genu of internal capsule have? Corticonuclear fibers and corticobulbar fibers. That's right. So we have to be very careful of the genu because it's in extremely close vicinity of the foramen of Monro. Usually we are entirely focused on the fornix. So this is one structure that we need to be aware of. Apart from that, you can see here the choroidal fissure and the choroidal plexus. You will also find the septal vein. There is another thing which happens around the foramen of Monro. What is that?
The venous angle
That's right. And how does the venous angle form?
by the union of the septal vein and the thalamus striate vein
That's
laterally.
right. So the thalamus striate vein and the septal vein, they join to form what?
The internal cerebral vein.
That's right. So this is extremely important. When is it important? Either we are going to proceed for the endoscopic third ventriculostomy, or we are going to take out any anterior third ventricular lesion or cyst, for example, the colloid cyst. So all these structures are extremely relevant to us from a surgical point of view. Let me see. While we are done with the illustration, you can take a look at the dissection now. And you can see foramen of Monro on the superior medial side, we are going to have the fornix. On the other side, we are going to have the genu, which is going to be very, very close. Now I'm going to mark the structures and some of you can probably volunteer to tell me what structures these are. Some of these are labeled, some of them are not. So this is visible, caudate, right? Caudate nucleus. And then you can see the rostrum here. Rostrum is a part of
Corpus callosum.
corpus
Corpus
callosum. And
callosum.
which fiber tract is going to be here within the rostrum?
The forceps major.
Forceps minor. Forceps major goes posteriorly. Anteriorly, we have forceps minor. So forceps minor is going to be here around the rostrum. Then if we come slightly posteriorly, you're going to find thalamus. You can see the thalamus here. Along with the thalamus, you will also see the fornix. Here you can see the body of the fornix, right? Which is meeting posteriorly. If we could dissect here, we would have seen the hippocampal commissure between both the crura of the fornix. then it travels interiorly. And once it travels interiorly, it separates into columns which dip anteriorly. Right? Apart from that, what do we see here? We see the choroid plexus and the choroidal fissure. We also see the thalamus right vein and the, what other vein are we going to see here?
Internal cerebral vein.
Yeah, this is the thalamus right vein. Which vein is this?
Septal vein.
Septal vein. So the thalamus right vein and the septal vein, they're going to join and they become the tributaries of the internal cerebral vein. So all of these structures we have done in thorough detail. When we zoom out from the same image, we can now see the insula and the basal ganglia structures which have not been dissected on this side. So we still do not see the cross section, but you can see some portion of the insula. So you know the orientation now. Let's move on. This is a zoomed out image of the same dissection level. You can now see the choroid plexus, the body of the lateral ventricle. You can also see some portion of the atrium and genu of the corpus callosum. Apart from that, in the second image, you can see all the structures that we previously discussed, foramen of Monro and columns of the fornix, which are going to make boundary of the foramen of Monro. And on the other side, we are going to have genu of the internal capsule somewhere around here. Are we all on the same page?
Yes.
Yes.
Now, can somebody mention what is going on here?
Entry to the foramen of Monro.
Entry through the foramen of Monro or entry from somewhere else?
Entry from the lateral ventricle going towards the foramen of Monro
Okay, which image are you talking about?
on the left.
Okay, the first image, I assume. Let me mark. This is A, this is B. So what is going on in the image A?
So as we enter through the lateral ventricle,
Mhm.
on the right, so we will see the foramen Monro. We can follow the choroid plexus, and we will enter the foramen of Monro. And laterally, we will see the thalamus right vein at approximately 5 o'clock. And on medially, we will see the septal vein.
So are we still in the lateral ventricle or we have moved beyond the lateral ventricle?
I guess we are in the roof of the third ventricle now.
That's right. So what is going on here? I don't see a dilatation of the foramen of Monro. So what is going on
It's
here?
moving from the image A is moving from the right to left through the septum pellucidum. The septum
Okay,
has been opened.
okay, and after septum, in the next image, what has been opened? Do you see that this has been marked in two
This is
different places? Why
posterior.
would that be? So what is this?
The posterior view.
This is a superior view. What is going on here? Okay, let's go back. This is a very interesting image. Part of the reason I included it at the end of this session. Let's go back. Uh-oh, I gave you a clue. Take a really good look at this. What do you see here? You see two fornices, or the body, or let's say two columns, right? Are you all with me? What is this? This is the septum pellucidum, right? Along with the septum pellucidum, there are two structures that run parallel that we did before. Which were those? They were fornices. This is body of one fornix. This is the body of the other fornix. This is one column. This is the other column. You all remember this C-shaped structure, right? We spent a lot of time doing this illustration. Do you want me to go back? Let's go back.
Yes.
Let's go back so that everybody is on the same page. Otherwise, it's not going to be fun. Let's go back. So you all remember this illustration, right?
Yes.
And all of you told me that this was the superior view or the axial view. We were looking at it from the top. So this was one fornix, this was the other fornix. In between there was septum pellucidum. Are you all with me so far?
Yes.
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 So moving on, let's come back here. Let's come on this image. This is, let's say, this is septum pellucidum. This on this side we have one fornix, on the other side we have this other fornix, and it moves interiorly, splits into two columns, right? So what is going to happen if I split the septum pellucidum? What else am I going to split as well?
Fornix.
Fornix, that's right. That is why you see two fornices here. The body of the fornix has been split open. This is an interfornical approach. We have split opened the fornices completely, and obviously it is a dissected image. Therefore, you can retract it to this point. Otherwise, you obviously would not be able to retract it in a live specimen or a live patient. But you can see that the foramen of Monro is completely intact here. The boundary is intact. Apparently, we are in the lateral ventricle if I hide everything deep here. So we are in the lateral ventricle. When I went into the lateral ventricle, what I did, I split open the septum pellucidum. Ideally, you should not even be in the lateral ventricle when you are splitting the septum pellucidum. You split the septum pellucidum, you are separating the fornices. Once you separate the fornices, you are going to land into the third ventricle, especially the anterior and the middle third ventricle. So this is an interfornical approach, and it is a dissected image of interfornical approach. Foramen of Monro is completely intact and lateral ventricle is completely intact. Am I clear?
Yes.
Yes.
There were a few other clues that all of you missed. This was the septal vein here. This was the thalamostriate vein, and it both of these were draining into the internal cerebral vein. But you could also see the internal cerebral vein on the other side, and we all know that internal cerebral vein cannot be viewed this directly from the lateral ventricle, right? Which means we have opened up the roof of the third ventricle. So this was a clue. And if you look slightly posteriorly, let me mark here. What is this?
The aqueduct of Sylvius.
Aqueduct of Sylvius. And on the other image, it is labeled, but it's not as visible. On this first image, it's visible beautifully. And on the second image, you can also see the pineal gland. So there were a lot of clues. The biggest clue probably was the intact foramen of Monro. Can somebody briefly go over the pros and the cons of transforaminal approach versus interfornical approach? We are going to cover the lateral ventricle approaches after we are done with anatomy, by the way. So this is the corridor, and this is how we go. Both of these use interhemispheric transcallosal approach. We are using the same corridor. This is a tubular endoscopic view, by the way. But the corridor that is used till the corpus callosum, it's the same. After we have split the corpus callosum in the foramen of Monro approach, we enter into one lateral ventricle. We enter into the lateral ventricle, and from the lateral ventricle, we can now see, let's assume there's a colloid cyst here, and that colloid cyst has enlarged this foramen of Monro. I'm going to mark it with green. This is the foramen of Monro, and these are the fornices. We are not going to touch the fornix here. This foramen of Monro is going to be a dilated natural corridor if there is, let's say, a colloid cyst inside. So this is the track which we are going to use. Whereas when we talk about the interfornical approach, Ideally, we should not be entering any ventricle. We would be doing a callosectomy. After the callosectomy, we are going to split the septum pellucidum and land directly into the third ventricle, the middle and the anterior portion, and we are going to create space between the fornices. Now, both of these have obviously their own pros and cons. Foramen of Monro is a natural corridor, and it's safer to use, but it cannot be used until and unless it is already dilated for some other reason. For example, there's obstructive hydrocephalus. You are approaching the patient for ETV, then this corridor can be safely used because it will be very, very dilated if you have first-hand seen the endoscopic view. Not be used until and unless it is already dilated for some other. Please keep yourself muted. So, we cannot use it until unless it is dilated, either due to obstructive hydrocephalus or, for example, due to colloid cyst or any other third ventricular region lesion which has now dilated the miniature foramen of Monro. Otherwise, you cannot use it. The interfornicial corridor is going to give you more space. It would be easier to look into the third ventricle. It would be easier to retrieve any lesion, especially the hypothalamic hematomas, for example, or the lesions of the middle and the posterior third ventricle. It would be easier for them. But what is the catch? What happens if the fornix gets injured?
Memory issue.
Which type? There are two types of amnesia. There are two types. There is one which is called anterograde amnesia, and there is one which is called retrograde amnesia or generalized amnesia. So retrograde or the other type happens when there is hippocampal injury. Anterograde amnesia is specific to fornicial injury. So if a patient, Dr. Ikhlas, you're writing on my screen. So if a patient gets his fornix injured, he has the chances of getting anterograde amnesia. That means patient won't be able to make any new memories. I believe there is a movie on anterograde amnesia of Adam Sandler's. I don't remember the name, but the lead actress develops anterograde amnesia and she is unable to make any new memories. So that it happens when your fornix gets injured. Interfornicial approach has a higher risk of amnesia and yes, somebody wrote akinetic mutism. Akinetic mutism, yes, but that is mostly complication of too wide of a corpus callosotomy. You have breached the traditional measurements of 1 to 2 centimeters and the callosotomy is longer than intended. Fornicial injury can cause akinetic mutism, but usually memory impairment is a more common manifestation. Oh, somebody mentioned Drew Barrymore, 51st States. That's right. I probably watched it probably a decade ago, so I didn't remember. But anterograde amnesia is usually a consequence of fornicial injury. So, ending on this note, we are going to continue tomorrow, hoping that you will all have a clearer understanding and orientation of different portions of lateral ventricle. We are going to cover the walls, the roof, the different parts, etc., in the theoretical manner tomorrow, inshallah. It's a wrap for today. To be continued, inshallah ta'ala. Thank you so much, everyone. Please leave me any questions or any feedback on the group. It was a pleasure coming back and doing this again. Thank you so much.
Thank you. Thank you, Mata.
Thank you. Thank you, Dr. Ikra. I saw your heart. Thank you so much.
Shukran.